Welcome to this webinar on innovation procurement as a vehicle to address healthcare challenges. This webinar is part of the EcoQUIP Plus procurement webinar series, actually the last one, unless we receive very strong demands to continue. But in our plans, we had these 6 episodes. And for the next 50 minutes, we will take you to public procurement for innovation world, really featuring 3 projects. Well, one is organizing and featuring 2 other projects, focusing on different healthcare challenges. One will be implantable pacemakers, and the other one will be a control system for antimicrobial resistance. We have invited 2 other, let's call them sister projects, to present their experiences. And although they differ at many points because they are funded under different European programs as well. One is a COSME project that will be Radar, and one is a Horizon 2020 project. RITMACORE, they are in different phases as well, because RITMACORE has already finished. Radar is in the middle of the activities, yet they have a lot in common to share with us. So we will tease out these key messages from our 2 speakers along 4 key topics. One will be the role of co-creation and stakeholder engagement. The other outcome-based procurement, outcomes-based procedures, sorry. Third will be impact evaluation, and the last one will be challenges. Before I introduce our speakers, let me just walk you through the agenda. So we will have this short introduction to the webinar. Then we will enjoy a 35-minute panel discussion with our 2 invited speakers. And then we will open the door, then the floor for questions from the audience. And we will close the webinar. My name is Annette Rosanov. I'm the Policy and Program Director from the European Health Management Association, EMA, who is the organizer of this webinar and the whole EcoQUIP Plus webinar series. We are a Brussels-based organization, non-profit association. Our members are health management organizations, and our mission is excellent health management for a healthy Europe. Let me talk you through EcoQUIP Plus, the COSME project within which we are organizing this webinar series. EcoQUIP Plus builds on the successful predecessor EcoQUIP project. And what we do in EcoQUIP Plus is public procurement for innovation. So we run 6 very concrete procurement projects on different challenges. You see these challenges displayed on the screen. We are active in 5 countries: Italy, Lithuania, Poland, Spain, and the UK. And what we do is we aggregate the demand from the hospitals, so we create a bigger market for innovative solutions. So that's all about the project. I think that will be enough. My colleagues are just posting in the chat the link to the EcoQUIP Plus website, where you get more information about these running projects. We are in the last year of implementation, so we will share loads of results actually towards 2022 with you if you are interested. So now let's go to the introduction of our speakers and housekeeping rules. So since it's a webinar, your microphones will be muted and your camera will be disabled during the whole session. However, you can type your questions at any time in the Q&A section that you can find at the bottom of the screen. Please remember that the chat is disabled for participants. However, my colleagues will be actively sending you useful information and links, but you can type in the question and answer box. And please follow us on EcoQUIP Plus Twitter, and use also the EcoQUIP Plus tag so that we can also retweet and like your messages. And now we are moving to the introduction of our two speakers. We will have with us today Sofia Moreno Perez, who is the procurement coordinator for RhythmoCore. As I said, RhythmoCore is a Horizon 2020 project, which has actually finished. And we will have Orman Elizondo, who is a Health Innovation Project Manager at Aquas, and part of the Radar coordination team. Radar is co-financed from the Erasmus, from the COSME program of the European Union. And with that, we can start actually the discussion. So I have given a short introduction to your respective projects, RhythmoCore and Radar. But Sofia and Orman, could you tell us a bit more about your projects? Please do not hesitate to share slides or images, figures, if you wish, that if those will have the better understanding. And during your presentation, if you could focus on the unmet needs, how it was identified, and how you used innovation, procurement to meet these unmet needs and demands. So who would like to start? Sofia or Orman? Who would like to start? Which one?
Go ahead, Sofia.
Okay, ladies first. Sofia.
Okay.
Welcome. Welcome, Sofia.
Thank you. Well, I will share some few slides just to make easier the understanding of RhythmoCore. Well, RhythmoCore is a Horizon 2020 project. It started in 2016 and finished last year. I think it has been one of the longest projects ever in Horizon 2020. We have 4 procurers, 4 hospitals, 3 Catalan procurers, 1 from UK. The lead procurer was the Hospital Sant Pau. In Barcelona, Mutua Terrassa Bellvitge Hospital, and Liverpool Heart and Chest Hospital. And then 5 supporting entities, Aquas, that was the coordinator. Here, my colleague Olman knows it very well. Valdinova, that is the company that I manage, that is a small consulting firm specialized in procurement, and some others. Well, what is the unmet need identified by RhythmoCore? Well, the unmet need is it could be a general one, and there is a continuous increase in the demand side for pacemakers for bradycardia patients, while the resources are not growing at the same speed. More concretely, resources in this case are 2 main resources. One are the devices themselves, but the other one that is very important also is the availability of clinical resources for follow-up. And this second one is really not growing as much as it would. So in these circumstances, the trend in most of the countries is to aggregate purchases to buy cheaper devices. And it has some secondary effects that are not so desirable. One of them is the misalignment of the interest of all the stakeholders participating in the care path of the patients. So the main goal of RhythmoCore is to increase the efficiency, making use of innovative pacemaker with high technology improvements that are out of the hospital now, because this policy of reducing prices. So aligning the interests of all the stakeholders to create a change of paradigms. From the vision of pacemaker implanting in a hospital-centered service to a patient-centered care service, where the relationship with the supplier became a partnership. So the main innovation in RhythmoCore is an organizational innovation, is the organizational transformation of all the care paths enabled by technology, and the level of change, the gun used to force the change is the purchasing approach, moving from purchasing devices to purchasing services, from paying per activity to paying per population, and adding an outcome-based payment model. And I think that we will go on with the next question. I think I consumed my time already.
Super. Thanks very much, Sophia, for this very clear introduction. And indeed, you have used keywords, which I would like to elaborate a tiny bit more. So if I understand correctly, you did joint procurement, just
yes.
like us in EcoQUIP Plus.
Yes.
And Orman, I think that you use something different, right? So PPI, but your PPI is not joint, but something different.
Exactly. It's a collaborative
it's
procurement.
Collaborative procurement.
Yes.
Okay, we will get back to there as well.
Yes.
But I will just let you explain what Radar is.
Thank you, and thank you, Sophia, for sharing that. It's a pleasure to be here with all of you. Let me just share my screen then. You see my screen?
Perfectly.
Okay, perfect. So, so I'm an innovation manager at Aquas, and right now the interim coordinator, as we had Yona Rizabalaga, who was supposed to be here, is leaving Aquas, but he has left a legacy of great coordination. So we will try to keep up with that. Let me just run you through what Radar is. Okay. First idea I want to introduce is that this is a new idea. So right now there's all this hype on AI, right? So what we are going to introduce here is a human intelligence, effort, which is Radar. Radar is a collaborative effort of a whole bunch of professionals and a whole bunch of institutions that are working towards finding an innovative solution to a common global problem, which is antimicrobial resistance. So what is the problem of MIR? In 2019, around 5 million people died from a disease that was in which AMR had something to do with it. And from that, 1.27 million were directly the cause of death. So there's estimated that around 2050, there will be more deaths on MIR than cancer. It is also an economic burden. So around 1.5 billion euros annually in terms of healthcare cost and also productivity losses just in the European Union. And most of all, it could decrease the efficiency, the effectiveness of the current treatments for two things. So the treatments that we use right now in terms of intensive care or at the surgery room in which we use antibiotics might become ineffective by this not proper use of antibiotics. So if we keep on doing that, we could have a serious problem in which the way in which we provide healthcare might be really, really affected, and this could have great consequences. So where is the need? Where does this come from? There is a global effort towards the MR problem. There's the joint action of antimicrobial resistance in the European Union, which they had the first EU JAMRAE, and it has led to the second one, which will start next year. And there was also the European Action Plan Against Antimicrobial Resistance, that was from 2017. And they have also helped us identify responses for this global problem. Some of them might be, for example, to improve early detection systems to ensure quality care process. Also screen drug resistance and virulence to improve the treatment effectiveness. Also reduce both healthcare costs and governmental costs. And then report and rapid communication systems to increase the system's resilience. So where do we come from? We come from anti-superbugs, which was a pre-commercial procurement in which we already in 2016 challenged the market. Aquas was also coordinator of this PCP. A PCP, as you know, challenges the market to provide to generate the research and development process so that you have a validated pilot of an unmet need. And in here, we asked for rapid detection of MDROs in hospitals. We were looking to improve the appropriateness of antibiotic usage. And we wanted to reduce the impact of hospital-acquired infections. So building on top of this, we've got RADAR, which stands for Rapid Detection of Antimicrobial Resistance. And we want to extend and leverage outcomes from anti-superbugs, but more than that, we also want to profit from all the new research and development that during the COVID-19 pandemic allowed us to accelerate on this field, both on the industry side, but also on the healthcare provision side. We are also bringing new procurement organizations. It's a different consortium that has established on this PPI, and we're also looking for new reimbursement models in which the value-based element is taken into account. Right. So our consortium is made up of 9 institutions. We have 4 buyers: the Catalan Institute of Oncology. We have UNINA, which is the University of Naples, Federico II, for the Campania region. We also have Biodonostia, which is the Basque National Health System, and Resa, which is a central purchasing body that is buying for the entire France. But we also have a very highly dream team of supporting entities like INSERM, for example, which is they are the coordinators of the first JAMRAE and the second one, which will come next year. And they have highly specialized in this topic. We have Biodonostia, who's providing support for us, like it's a procurement process. We are at Aquas, we're coordinating, and we're supporting also through the Catalan health system and the global vision of this. And we have INSME, which is international network of SMEs that is helping us connect with SMEs, not just in Europe, but around the world. And Jura Consulting, which is consulting and highly specialized on procurement of innovation as well, helping us here. So the last thing I wanted to show you is this collaborative cross-border procurement model. This is also an innovation of this case of procuring, because we are all working collaboratively on defining what the clinical demand as the MR problem, as you might all understand. It's a global issue, but there's also has some local elements that influence on the clinical perspective. So by working this collaboratively, we're trying to identify those general elements and the peculiarities that each of the buyers might have in their own settings. We had a market readiness assessment phase in which we had an international event and 4 local events, one in Barcelona, one in Naples, in France, and one in Donosti, in which we engage with the industry to understand where the market is in terms of providing, similar solutions to the unmet need that we're presenting. And we have had a great interaction with the industry. They've shown great interest, and this will lead to 4 different individual tendering processes that are coming. And this is also because each one of the local legal procurement, let's say, frameworks is different in each case. So this could also facilitate the way in which the contract will be signed, because each one of them will sign a specific contract. So there will be 4 economic operators consortia delivering this 4 contracts over an execution period. And our aim, in working collaboratively here, is to generate also some evidence once we get to that end of the line, so that we can foresee the value that this has had on the implementation. And that's all I have to share with you. Thank you.
Thank you, Roman, for again very clearly highlighting the global challenge, which is AMR, combined with local characteristics or local elements, and how this collaboration is brought together across the buyers, the 4 countries. I have noted very powerful words, actually, the transformation, change management, and of course, for both of you, collaboration and stakeholder engagement, co-creation lie in the heart of both projects. So, Sophia, first, how this co-creation helped to drive RhythmCore, and why is it so important in public procurement for innovation?
Well, I would like to differentiate 2 different co-creation processes.
Okay.
The first one, during the preparation stage of the project, RhythmCore was launched many years ago, and it was somehow a pioneer in digital transformation. So things were not so clear then as they seem to be now. Then first thing that we need to do was to adapt to the usual practice of clinicians. Clinicians had a short time, hate the European jargon. They don't want to listen about work packages or deliverable of these words. They want to discuss in their own words and in their own terms. And so we first of all adapt to this. They have short time and their own way of discussing. Then at the very beginning, we have to set up the vision of the project. Once we had the vision, we created what we call the pillars, divide and conquer. So we define several concepts, the remote monitoring, the coordinated care, the patient activation, the change management, the personalized therapy, and the risk sharing. And around this concept, we had discussions, and we used some tools like the patient journey to make them flow. And from this discussion, we, the knowledge partner, started to write down a document that was like the reference for the things that we were doing, and that they could read and re-elaborate, etc. What I want to emphasize from our co-creation process is that, in fact, the most interesting thing is that it allowed a progressive empowerment, a progressive mutual encouraging of the clinician, who became more and more ambitious in their vision and the scope that they were aiming to develop. Because there was an initial fear that was overcome, because the vision of Ritmo is developed to stay. It's a long-term vision. So it's not a pilot. It's not an experiment. It's there to stay. So it's a serious thing. So at the very beginning, clinicians were slightly fear of what to do or not. And also it is involving a lot of many people, like in the coordinated care, it involved primary care, it involved the intervention of the suppliers, etc. So this mutual encouraging was very beneficial for the final scope of the project. And then the second area of co-creation that maybe we will discuss later is between the service provider and the hospital, that also need a process to close the governance, to close the details, and to deploy the project inside the hospital.
Okay, so I see that you had, on the one hand, co-creation with the clinicians, and then between the demand and the supply side. Yeah, and then how the kind of convincing the clinicians was a great success for you, and how it empowered more ambitious thinking. And Orman, can you draw a kind of parallel line to what we heard from Sophia? So which stakeholders did you co-create with, or did you engage with, or are you engaging with? Because I understand that it's still an ongoing process in Radar.
Yes, exactly. I'm completely aligned with what Sophia just mentioned. When you start a PPI project, there are different levels of maturity on the topic of deploying procurement of innovation. So it's kind of a complex thing. So you need it needs sort of a slow maturity and picking sort of the right people that to be involved at the right time. So you have all the consortium member teams, you have the clinical champions, which is always important to have on board. And then they, again, are going to act, as Sophia mentioned, sort of as the carriers, the feedback loopers towards their own teams and their organization to involve many different actors in this process. So in our case, for example, we're talking about a highly microbiological topic. So it's very, very specialized, but it also has a clinical impact on almost any service. But then here, you also have to allow them to provide the different experience that they have in their own organizations, not just in the, let's say, the lab part of it, but also on these different areas, right? So in this case, when you are dealing with the MIR, what you're trying to see is you want a rapid detection so that you can control something that is already an outbreak or a colonization. So it's sort of a case in which the entire healthcare setting is at risk, and that we need to act upon it the best way possible to coordinate already many different actors. So what we're doing here is actually getting all these people ready and on board to provide their perspective, their points of view, their ideas, And first we started with those microbiologists trying to nail down what's the clinical demand. But soon it gets to the clinician that you might have, you know, a first-year resident at the emergency room having to take a decision, which of course there's always, you know, support from, you know, higher ranked clinicians or whatever, but you have to take into account all the different elements that on that patient journey might identify elements that might be important to take into account once you're trying to define exactly what the unmet need is and what your clinical demand is going to be for this procurement process. The other thing I want to say is that it is a procurement, so you will involve at some point during the process a call for tender, and that comes from a different dimension within the hospital organization, which is the procurement offices or the economic and financial offices, which they have a lot of experience in working with this, but not precisely or not necessarily on procurement of innovation. So it's a thing, and they have to get introduced to this. And on most of the procurement of innovation, there's also this technology aspect, for example. So the involving the IT department at some point, since there's going to be an innovative solution, which we don't already know which one is going to be. They need to provide also the elements that could allow us to prepare. And all these different stakeholders that we're engaging are helping us permeate value on this call for tender documents. That when we procure, then these specificities, these elements that are on this document are for, let's say, the purpose, as Sophia was mentioning, to actually transform the health system, right? In terms of, we don't have a solution for our unmet need because we've looked and we've done horizontal scanning, we've done state of the art, and there are things that help here, but none of them actually resolve my problem. So focus on the need first and start bringing all this stakeholders that could permeate value onto your process, which at the end of the day, you're going to have to deploy with them. So they're going to be part, not just at this phase, but once you have the economic operator that is awarded, then you have to, as Sophia said, work collaboratively with them to deploy it and then to execute something that you want for a sustainable and a new approach to face this situation.
Yes, thanks very much. So it's becoming, I think, to the audience more and more clear really what the difference between doing collaborative and doing joint procurement. So looking, really generating the solution which doesn't exist in Radar, and Sophia transforming processes to be able to better use and better follow up and procure at lower prices the existing solutions already. And for Oman, I can really see how you draw the kind of process and stop at different stages. Marston, you say, which are the stakeholders I will need here to co-create with? Which are the stakeholders here that I will know what they need? So when do I involve the IT department, the procurement department? When do I involve the microbiologist and the clinician? So yeah, we see really these maps becoming clear. Sophia, you mentioned in your introductory presentation a new model, a payment model, outcome-based payment model or strategy, which you introduced. Can you explain that a tiny bit more in details to us, what you mean to it and how you used it?
Sure. The most innovative pillar of RhythmoCore was what we call it the risk sharing or outcome-based payment pillar. In fact, in RhythmoCore, we had several elements that made this business approach very different. One was moving from purchasing devices to purchasing a service. This is a very big change, and then moving from paying per devices to paying per population within some threshold, of course, and then a risk-sharing of the complications. So if there is an infection, for instance, that demand to replace a pacemaker, this is very painful for the patient and very dangerous and very expensive for the hospital. And in the aggregation model, sometimes the suppliers has no responsibility about it. So there is this resharing of complication, the paper population, the paper service, and then a 5% of the overall budget is an outcome-based payment of the annual payment. The objective here is to have a partnership, and the KPIs are defined in such a way that the most usual thing, if everything goes normal, is that the supplier gets the 5%. So it's not for punishment, but for fostering this alignment. And I think that I will show you a slide just for clarification of these KPIs, because could be relevant. But the definition of these KPIs is the critical point in the outcome-based definition, because when you have the adequacy in the definition of these KPIs is what will facilitate the good or the complete alignment or not of the work of the service provider and the healthcare system. So the right definition of these KPIs is the critical point. The process that we follow to define these KPIs was to go through each of the pillars and to go through the complete scope that we previously defined with all of them through this co-creation process, and working again closely with the clinician, trying to identify KPIs that could be the responsibility of both the supplier and the healthcare system. In this model, the supplier are a partner working hand by hand with the clinician. It's not only someone giving you the devices, but giving you everything you need and you don't have, and assigning them a measure of the responsibility that could be medium, high, or low. Let me share this slide. Here you can see this figure on the right, where for each of the pillar we have several areas of to be measured, such as the waiting time until implantation, the level of complications, the number of patients using the app, the number of patients involved in the activation program. So we had a long list of indicators, but trying to make it as simple as possible and very tailored to the actual intervention of suppliers.
And of course, going back to the co-creation and the stakeholder engagement, as you said.
Yes, that was another iteration on co-creation.
Yes, indeed, indeed. So I understand, Sophia, that the definition of these KPIs actually lead you already to the impact definition or the impact evaluation, right? And
absolutely.
Bringing it forward. Yeah. So
absolutely.
Very clearly. Yeah. But we will come back to that in a moment. Orman, can you relate to this outcome-based procedure in Radar? Just very quickly, because we are running a tiny bit out of time. So can you relate to that?
Yes, absolutely. We have also in Aquas, we've sort of in each project that we have participated, we've learned from the experience, and we have also dedicated some time to sort of define methodologies that could be applied to this. So, and we're part of a community of practice, which was an European funded project, which is called PP, which stands for Platform for Innovation and Procurement, for Innovation Procurement and Procurement Innovation. And one of the outputs of that project was to define an agnostic result method, agnostic results for a PCP PPI, right? So we've evolved on top of that, and we've created sort of a methodology of a permeability of value, in which we have 5 different levels of understanding what the value from the demand side is in terms of what are the expected results we want to achieve with this innovative solution. So starting from the patient, you know, and then you have healthcare professionals, you have the healthcare provider, you have healthcare system and society as a whole, right? And this has a list of those agnostic results in which each one of the buyers then will work on determining if those expected results and outcomes are going to be significant or important for this specific procurement and for that specific buyer. And through this, we're also generating sort of an improvement cycle of how this methodology, in each case it has been used, which was used in Ritmo as well. And I know, in Ritmo I don't think we did it, but might have been, I don't know. But in any case, we were building on top of all the knowledge that we bring from the different projects there is. And we've created this community of practice because we think that the more we can learn from different stakeholders that have participated in this, the better we will be able to allow other new procurers that have not had the experience, institutions and professionals. So we always have this double, you know, relationship with this project, with the projects that we work on as a person and as an institution, and to bring this lessons learned so that all these elements that from Red Book project or from the Radar project could be brought into better results in the procurement of innovation process. So all of this leads to, let's say, value-based procurement. We want all those elements to be defined on those call for tender documentations, and that would allow us to do several things at the time. For one thing, we will define an awarding criteria that is value-based because we have permeated all the different items and things that all these professionals have put into this document. We will also here determine which are going to be the criteria in which we select those economic operator proposals, but also it's marking towards how are we going to execute this project once we have the plans and the proposals from this, in a phase in which we deploy and then in a phase in which we execute. And at that point, as the Ritmo Core example, once you evolve and reach to that conclusions, the level of lessons learned allow, let's say, the scaling of that solution and also the scaling of the procedure that was used, because it might be used for a different type of unmet need, or it could be used to continue the procurement of this new innovative solution, right? So we're focusing on those new markets and how we can provide all the value, and then the complementary value comes from the industry, the way they play along by understanding the hints that we're providing on where we think this market should lead to.
Yeah, and this is what you will use for scaling up. Before we turn to the questions in the question and answer box, thank you much to the audience for posting those. Coming back just to the impact, Sophia, would you like to add anything that built on the KPIs, what you have already, how you measured impact, just very, very quickly? Would you like to complement?
In our case, it was simple because it was linked to the payment to the service provider. So it was measured every 3 months. And I have a slide with some data. Do you mind if I show it very quickly?
Yeah, very, very quickly.
Some few, just to remark that, for instance, there was a reduction in death related to pacemaker from 1% to 0%, and the reduction of major complications. Well, you have the figure on the screen. I will not read them, but there have been some detection of atrial fibrillation and a stroke prevention that was never done before, even if the devices has the capacity. That this is just as a screenshot to share with you that we are very satisfied with the result of RhythmoCore. And one thing that was not so important at the beginning was the patient experience that has been extremely satisfactory and deserve some further discussion, but I guess we have no time for that.
We do know, but actually Orman mentioned that as a kind of social value, right? That you consider. Orman mentioned the patients in the first place. Orman, I know that in Radar you are a bit further away yet from impact evaluation, but what are your thoughts? What are your plans?
Well, this the impact it's based to this, let's say, probability of value, because let's say we use the impact is on the long-term results, right? We won't be able to evaluate those that long-term results over the execution period, but we've already signaled what would be those results at long-term, mid-term, and then what we will be able to assess is the short-term elements that are going to be introduced in the deployment and the first execution of the projects. And that's where we stop. But by doing all of this effort to put those on the call for tender, it means that the value is not only for the economic operators that get awarded, but by all of the economic operators that actually use this opportunity, both in market, open market consultation events, in which they can already foresee what elements could lead their strategic adaptation, and also on what is their progression, even if they don't get awarded. Okay, if the market is going to move towards this place, then we might adapt our value proposition. We might need some complementary partnerships, right? Most of the procurement innovation deal with unmet needs. There are things that off-the-shelf products are not providing. So most of the time, it would need some sort of collaboration and coordination among maybe different actors that are not on the same field, but that this complementary partnership to solve or to give response to our unmet need is actually what we're looking for. So here we're also providing some impact in terms how the relationships from the industry, the supply chain, and the demand side, it's compensated because we're making an effort on the demand side to do this co-creation and this value permeability towards this process, so that we can trigger the transformational element that those innovative solutions will bring.
Yeah, thank you for highlighting that. Taking some questions from the question and answer panel, because we are running over time. I think that we have already responded to the outcomes, and I'm encouraging you, Sophia and Orman, to respond yourself. You can do that. Then I will go to collaboration or cooperation across different value chains. What are your thoughts about that?
Could you please make the question?
Yes, when you talk about joint cooperation, I think that it was joint procurement. What are your thoughts about working together in different value chains?
Well,
across, I imagine across different value chains.
Yeah, in fact, one of the problems that we faced during Ritmokur was to find procurers because for instance, we couldn't work with Bismarck procurers because their healthcare model was too different to our model, and we could not work with them in moving from devices from activity to population, for instance. So at first, in Ritmokur, it was very demanding. The initial alignment was very demanding in the sense that we need coordinated care with primary care, etc. So we need a system where already this alignment, the basic rules were established, and then after our most difficult thing was to realign the value change from the industry that need to move from just selling devices to provide complete services, including IT platforms, etc. Moving from just moving boxes to providing a full service and development things. That was the main challenge that we faced. We were taken on court even by some of the potential candidates, and we won. So that was good for the model. But if you are trying to, if you have a model of digital transformation, that is what Ritmokur is, with a defined final point in a joint procurement where the differences are only some figures, not any of the concept, the starting point need to be more or less aligned, cannot be totally different.
Thank you, Sofia. Sophie, Carly, Sofia Moreno is typing the answer to your question, and analyst the role of patient organization, Allman is kindly typing in the question. So with these, I would like to actually conclude the questions and answers, and just quickly try and summarize what we have learned, because we are running out of time. But it's very my personal conclusions. The transformative power of PPI, which we have learned here, really, as Sophia summarized, organizational transformations, change management, or introduce and triggering change, shifting the view from product to service, taking high risks, even because you don't play with pacemakers, right? So it's really patient safety and patient lives, but it is for really increasing innovation and reducing prices, and also shifting to population payments, so outcome-based payment models, which is key for Allman. The co-creation model and planning ahead to impact evaluation is what I have learned from you, and actually encouraging suppliers to come up together with solution, because you cannot buy in the solution from one single supplier. So that changes the suppliers' collaboration between themselves. And what I have also learned from you, Allman, is even if you are not selected as a supplier, you are a winner, because you win in terms of learning, in terms of perspectives, in terms of opening up your mind and learning the relation, how to manage the relation with the demand side, with healthcare providers. So with that, I would like to close this this discussion. And what remains to us is just inviting the participants to join the Collaborative Buyers Forum. My colleagues will put in the chat, post in the chat how you can join the forum. We will obviously produce a short report, and we will make the recording of this webinar available. Watch out on the EMA website and the EcoQUIP Plus website, where we will post these. We would also like to warmly invite you to the EMA conference between the 5th and the 7th of June in Rome. Registration is still open, where we will host an EcoQUIP Plus workshop. So if you would like to further explore PPI with us, we will actually explore how health technology assessment can be a useful tool to guide us in innovation procurement. Safer, more efficient, more effective, more environmentally safe, environmental friendly solutions that we can procure. And I know that Allman also has an event which you would like to publicize, Allman, here. Perhaps if you could put in the chat, post in the chat the link to the tomorrow's webinar, which will be the launch of a platform, PPCOP post phase of an EU project. If I summarize that correctly, Allman, this is a platform of a former EU project, right? Which will be relaunched.
Exactly, the community of practice. And in this case, it's the first webinar that we do after the EU-funded phase. And so we will then discuss some of the experiences from the policy making that the Catalan health system is using procurement of innovation, the adoption of procurement of innovation as a way to this demand-driven transformation system, and working with different healthcare providers that collaboratively will prepare those procurement of innovations and it's a way in which we're using the next generation funds in a way that transparently can engage the industry to provide this solutions that will help to transform our health system and make it high value care.
So if you want to meet Allman tomorrow, then you can still register.
Exactly. I don't know where to publish it actually.
Either the chat, it's in the chat panel.
It's in the chat already?
Chat panel,
okay.
Yes, yeah.
Okay, thank you.
You can post it. And actually, this is also another conclusion we can draw, how many financing instrument you can use for your PPI ideas. We can see Horizon 2020, COSME, and the Next Generation funds as well. So just for the audience. Apologies for running over time, and now we will really have to close. Thanks very much for participating. I think it was a very useful, rich and inspiring discussion. This is why we are also running late. It is really difficult to stop now, but we are very happy to have Allman and Sophia with us today. Thanks so much. And let's keep in touch, perhaps on the Collaborative Buyers Forum and on EcoQUIP Plus and other PPI project channels. See you next time.
Thank you, everyone.
Thank you. Bye-bye. Bye.